Hello, I'm Dr. Ayesha Siddika. I have been practicing medicine for the previous 5 years in Bangladesh. Moreover, I am a GMC registered doctor and I am currently preparing for my Royal College exam, and I am going to share the topics that I am reading with you so that we can learn together. So we have already mentioned the asthma assessment clinical feature. In this video, I'm going to discuss about management of asthma. First of all, I'll discuss about management of chronic asthma. Then I'll discuss about management of acute severe asthma. Okay, so first of all, I'll talk about non-pharmacological approach. We have to check certain things before giving the drug management. So if patient is using inhaler, so we need to check that if the patient is using the appropriate technique of inhaler use. Then we'll advise the patient about avoiding triggers. That means avoiding exposure to allergen or any triggers. Then we'll advise if patient is obese, then about the weight loss and smoking cessation. We'll tell the patient to follow up annually. If there's any exacerbation, then they may need to follow up more frequently. Okay, then how we'll monitor the patient? We'll monitor based on asthma control test or questionnaire. And also we'll tell the patient to maintain peak expiratory flow diary so that we can understand that how the control of asthma he or she has. Okay, so we'll talk about management of asthma. First of all, adult and children. So in children 5 to 16 years, it is more or less similar to management of asthma management in adult. But in case a patient is less than 5 years, it may slight difference. There may be slight difference in managing children less than 5 years. So first of all, we'll talk about adult. We'll give SABA. For shortcut, we'll first say the name only. So at first stage, we'll only give SABA. That means short-acting beta-2 agonist. Then step 2, we'll add low dose ICS, means inhaled corticosteroid. Then in third step, we'll give LTRA, that means montelukast. Okay, so leukotriene receptor antagonist, that is montelukast and LABA. Fourth stage, long acting bronchodilator, that is a long acting beta-2 agonist, LABA. So we'll give SABA, ICS, montelukast and LABA. I have made a mnemonic for this, SIMLA, SIMLA. S for SABA, ICS, montelukast and LA for LABA. So first 4 step is SIMLA. Then we'll add low dose MART. What is MART? It is maintenance and reliever therapy. We combine two drugs in a meter dose inhaler, like low dose ICS plus LABA, that is low dose MART. In sixth step, we'll add moderate dose MART. Okay, that is moderate ICS plus LABA, moderate dose ICS and LABA. And 7th stage, there is no MART with high dose ICS, so we'll give them separately, like high dose ICS plus LABA. We can add theophylline and oral steroid at this step. So, and if we can't control at this step, we may need to refer the patient to a specialist. And in children 5 to 16 years, it is similar to this, like SABA, low dose ICS, montelukast, and then there is low dose MART, that is low ICS plus LABA, then moderate dose ICS plus LABA, then high dose ICS plus. During giving high dose ICS in children, we need specialist advice, and also we can give theophylline. So this is more or less similar to management of asthma in adult. Okay, then we'll discuss about management of asthma in children. Children less than 5 years. So here, first of all, if we suspect asthma, first of all, we will introduce pediatric moderate dose ICS. If there is need for maintenance therapy after giving SABA, then we will give moderate dose ICS for 8 weeks. Then we will observe, like if symptom resolve or not. If after giving 8 weeks of moderate dose ICS symptom persist, then we have to look for alternative diagnosis. And if symptom resolve, then we have to wait for 4 weeks. Like if the symptoms reoccurred within 4 weeks of stopping ICS, then we'll restart pediatric low dose ICS at maintenance, first line maintenance therapy. So if it reoccurred within 4 weeks of stopping ICS, then we'll start low dose ICS as first line. And if it is reoccurred beyond 4 weeks of stopping ICS, then we will repeat moderate dose ICS for 8 weeks. Okay, and we will follow the same flowchart again. And if it is uncontrolled after giving ICS and SABA, then we will give montelukast. And if it is uncontrolled, then we will stop the montelukast and we will refer the pediatric patient to a specialist, like in case of less than 5 years. Now we'll talk about inhaled ICS not tolerated. That means if the inhaled corticosteroid is not tolerated, then what we'll do? Like steroid naive individual, we can give montelukast if patient is less than 5 years. Okay, then we can give sodium chromoglycate or nitrochromyl sodium or theophylline. If any doubt about the management, we can always take advice from a specialist. So what will we do if asthma control deteriorates? Then we will increase the ICS dose for 7 days. In case of children 16-year or more than 16-year, okay? And we can't increase the dose in combined inhaler, so we'll increase the ICS dose in single ICS inhaler. And but we have to be cautious that it does not exceed the maximum dose, okay, for that age group. Then also we'll initiate asthma action plan. So what is asthma action plan? So we have to educate them what to do if there is no symptomatic improvement, and we will educate about when to increase the ICS dose, okay? So at this point we have already talked about management of chronic asthma. Now we will talk about acute asthma. So there is 3 types of acute asthma, like patient may come with acute severe asthma, patient may come with life-threatening asthma, or near fatal asthma. So how we'll understand that it is an acute severe asthma? The respiratory rate will be more than 24/5, and heart rate will be more than 110, and peak expiratory flow rate will be 33 to 50% of best or predicted. Okay, there will be a speech problem, like patient will not be able to complete a sentence. Okay, so respiratory rate, heart rate, peak expiratory flow rate, and a speech problem. We have to keep this in mind. Okay, then life-threatening feature. So respiratory rate will be feeble or maybe silent chest, and heart rate, regarding heart rate, bradycardia, arrhythmia, or dysrhythmia. Okay, what will be the PEFR? It will be less than 33% of predicted or best. Okay, there will be normal partial pressure of carbon dioxide, and oxygen saturation will be low. There may be cyanosis, and blood pressure will be low, and there may be exhaustion, altered mental status, or confusion. Okay, so when we call this life-threatening feature to near fatal, if there is raised level of partial pressure of carbon dioxide, then we'll say that this patient is near fatal. Okay, so what investigation will it do in case of asthma is mostly clinical diagnosis, but if there is low level of saturation, oxygen saturation less than 92%, or hypoxia, then we'll do arterial blood gas. Okay, A, B, G. Then we'll do the chest X-ray to exclude the pneumothorax. Okay, now we'll talk about management of acute severe asthma. I have made a mnemonic for that. That is OSPIMA. OSPIMA. O for oxygen, S for salbutamol, P for prednisolone or hydrocortisone means steroid, I for ipratropium, M for magnesium sulfate, A for aminophylline. Okay, so first of all we'll give high flow oxygen 15 liters per minute through the non-rebreathable mask. Then we'll provide salbutamol plus minus ipratropium bromide through the nebulization. If no improvement, we may need to give IV salbutamol. Okay, then we'll give prednisolone par orally or hydrocortisone IV. Then we may need to, if no improvement, then we may need to give magnesium sulfate IV. Okay, then single dose. Okay, and with senior supervision, we may decide to give aminophylline IV if there is no improvement. Okay, or if there is no improvement after all these steps, we may need to refer the patient to ICU. So what is the criteria for that? When we'll refer the patient to ICU? So if there is a declining level of PEFR, okay, then there is a declining oxygen despite all this effort, oxygen saturation is falling, and peak expiratory rate is falling, and there is rising carbon dioxide and falling pH, that means acidosis, so respiratory acidosis. Okay, and there may be respiratory arrest, exhaustion, and altered level of consciousness. Then we need to refer the patient to ICU. So when we discharge a patient, there is some criteria that we can follow. Like if our peak expiratory flow rate is 75% of patient best or predicted value, okay, 75%, it should be 75% or more. And variable peak expiratory flow rate is less than 25%. So diurnal variation will be less than 25%. And there was no need for nebulization for at least 1 day. Okay. Then we have already given the patient written asthma action plan. We have given the patient the education about asthma, also inhaler use techniques. Okay, and we have to ensure the follow-up in primary or secondary care within 30 days of discharge. After following all these criteria, we can discharge the patient. Okay, what is the prognosis? So early diagnosis will lead to better prognosis, and we have already mentioned that in childhood it is more common in boys, and adulthood it is more common in women. Okay, so young boys are more likely to grow out of asthma as they become adult. So this is it. We have already completed the management of chronic asthma and acute asthma. Okay, thank you for watching, and we'll discuss about another topic in the next video. Okay, bye bye.